So we're going to talk about assessing patients with lower GI complaints. So in general, when we're talking lower GI complaints, we're looking at items like constipation, diarrhea, gas, bloating, as well as abdominal pain and rectal pain or bleeding. Now, these complaints may be due to a physiologic cause or a functional disorder. By functional disorder, what I'm referring to is that it may be related to the nervous system as it's functioning inside the muscles of the area of complaint, or due to the nervous system from the spinal cord to the muscle, or from the nervous system from the brain downward. Now, no bodily function is more variable and subject to external influences than defecation. Bowel habits vary considerably from person to person. They can be affected by age, physiology, diet, as well as social and cultural influences. Now, normal bowel movements may range in frequency from 2 to 3 per day, all the way down to 2 to 3 per week. Now, nutritionists will often tell you, however, is that anytime you're putting food into your mouth, within an hour to 2 hours, a healthy individual should have a bowel movement. Now, when it comes to changes in stool frequency, like constipation, diarrhea, for example, as well as consistency, how often they're going, volume, the composition of it, if there's the presence of blood, mucus, pus, excess fatty material, all these changes may indicate the presence of disease. So, the color of stool can have different meanings. Black stool can be due to upper GI bleeding, in which we have the presence of melena, for example. Food and supplements can contribute to this. Things like licorice, blueberries, supplements like iron supplementation. Also, if somebody is being inadvertently taking in lead, may produce black stools. And then Pepto-Bismol can produce the side effect of black stool. Green stools can indicate an increase in the presence of bile. Can also be contributed to by eating lots of green leafy vegetables or taking chlorophyll tablets like for halitosis. And green stool can be normal in breastfed babies. Red stool color could be from frank blood loss from lower GI bleeding or from eating lots of beets or tomatoes, for example. Gray, also referred to as pale stool or chalky white stool, can be indicative of organic issues like liver problems, pancreatic problems, gallbladder problems. So for example, if we have an issue with the breakdown of bilirubin, we're not going to have the necessary constituents that contribute to giving the stool its brown color. So then the stools will become very gray. So that could be indicative of a liver problem. Yellow can indicate an increase in bilirubin, like hyperbilirubinemia, or also seen with Gilbert syndrome. But yellow can also be linked to parasitic infection, and the most common etiology for that is Giardia. Most common mode of onset for exposure to Giardia is drinking fecally contaminated water. Constipation is defined as difficult or infrequent passage of stool, hardness of stool, or a feeling of incomplete evacuation. Now, there are people that may incorrectly believe that daily defecation is necessary and complain of constipation if stools occur less frequently. Others may be concerned about the presence of constipation if there's a change in the appearance or the consistency of the stool. Constipation is blamed for many GI problems that are actually symptoms of an underlying disease of which their constipation may be a part of. So typically, constipation is not a standalone diagnosis in and of itself. Now we have two types of constipation. Acute constipation, which typically suggests a physiological cause, and then chronic constipation. And chronic constipation can be either physiological or functional in terms of etiology. Etiologies include diets that are low in fiber, side effects of medications, narrowing or blockage of the colon, hormonal disturbances, muscle diseases, age, and lack of exercise. So, let's look at a few of these in more detail. With the side effects of medications, there are several med groups or medication groups that are known for contributing to side effects such as constipation. They include narcotic painkillers, products like Tylenol 3 with codeine, Percocet, Dilaudid. Antidepressants are another group, such as Elavil or Prozac. Anticonvulsants, iron supplements, calcium channel blockers like Cardizem or Procardia, as well as antacids and laxatives can produce constipation as a side effect, especially when individuals overzealously use laxatives. The body loses the ability to then recognize the need to defecate on its own, and it may contribute to constipation. Now, with narrowing or blockage of the colon, we can often see the presence of ineffective contraction or spasms of the muscles of the colon contributing to this. Hormonal disturbances, we're going to look at systemic conditions like hypothyroidism or diabetes, for example. Muscle diseases, basically neurogenic conditions can contribute to this. Two examples would include Parkinson's disease as well as multiple sclerosis. As for age, over the age of 60, the patient's nervous system and reflexes will often decrease, and they may not sense that they need to go as often as before. In fact, fecal impaction is very common in the elderly patient. Now, as for treatment, it includes a combination of things. Increasing fiber in diet is the first option. It helps to increase bulk to the stool, soften the stool because it's going to cause water to be drawn into the stool. This is going to then produce distension within the colon, which will in turn stimulate greater peristalsis. So we have increased peristaltic contractions, softening of the stool from the water addition, and it's going to help it to move forward more readily. Increasing water intake. If a person is dehydrated, they will not have adequate water available for drawing into the fecal material in the GI tract, in the colon specifically. And then the addition of regular exercise, such as walking, swimming, or running, to stimulate skeletal muscle activity, which may help with this. Behavioral changes are another option. For example, patients can look at trying to basically change their behavior in terms of trying to move their bowel at the same time each day, preferably about an hour after eating, and see if they can get the body into the habit of defecation regularly and decreasing the constipation. Now again, like I mentioned previously, with the use of laxatives, some patients not only use them, but they can abuse them. They can use oral laxatives, suppositories, enemas, and with this overzealous treatment, patients can develop what's known as colonic inertia. This is known as atonic constipation or colon stasis or inactive colon. And again, this is where the colon no longer responds to the usual stimuli because the rectum loses its sensitivity to the fecal masses and the patient just doesn't feel a need to defecate. Now, when individuals have issues with chronic constipation, upon proctoscopic exam, the walls of the colon will show a dark brown pigmentation that is called melanosis coli in those individuals that use laxatives regularly, and especially if they abuse them. And the melanosis coli is a benign, reversible condition, and it's usually associated with long-term laxative use, and it produces a brown-black discoloration of the mucosa. Let's talk about dyschezia, and this is also known as disordered evacuation or dysfunction of the pelvic floor or anal sphincters. This is defined as difficulty in defecation that results from a lack of coordination of the pelvic floor muscles and the anal sphincter. Now, these patients will typically feel or sense that stool is present, but they cannot defecate because the pelvic floor muscles or the anal sphincter muscles do not relax when the other set of muscles is working. Now, the actual stool frequency may or may not be decreased. This is considered an acquired behavioral problem from childhood or from irritable bowel syndrome. And if the patients try to sit and strain at the stool, it's futile. It's not going to help this. Diagnosis of this is through anal rectal manometry. So let's look a little closer at laxatives. Number one, laxatives should be used carefully because some of them may interfere with absorption of certain medications that the patient's on. Some of them can cause rapid fecal transit that's going to push the drug and the nutrients past their optimal absorptive locations, so they may not be able to adequately absorb their medications. There are several contraindications to using laxatives. They include the presence of acute abdominal pain of unknown origin, in the presence of inflammatory bowel disorders, in the presence of intestinal obstructions, with GI bleeding, as well as with fecal impaction. So there are several types of commercial laxatives and each works in different ways. So wetting agents are the first type, and these are a detergent laxative and they soften the stool so that it'll be easier to pass. So these wetting agents break down the surface tension of the fecal material, allowing water to enter the fecal mass to soften it and to increase its bulk. This is going to stimulate peristalsis and move the softened stool more easily. Now this particular type of laxative works very slowly. The next type of laxative is osmotic agents. This type of laxative speeds up defecation and is used most often to prepare patients for diagnostic tests such as colonoscopies. Now these agents contain magnesium phosphates, sulfates, lactose, sorbitol, or a combination of these, and this type of laxative is going to increase the intraluminal osmotic pressure. So it's going to draw lots of water into the intestines and stimulate peristalsis. These agents work within 1 to 3 hours. Now, bulking agents, the final type we're going to talk about of these commercial laxatives. Bulking agents are laxatives that contain natural sources of fiber, like psyllium, agar, kelp, plant gum, or even synthetic cellulose compounds. They take anywhere from 12 to 36 hours of work to work. Examples of them include products like Citracel, Metamucil, and Metamucil is a laxative that's used as a fiber supplement as well as a laxative. There are some natural laxatives that work like bulking agents. They include bran, psyllium, and calcium, and these all provide some degree of fiber and are acceptable for long-term use. They can also be used to normalize stools in the presence of diarrhea as well. So commercial laxatives can be effective, but they can also cause many problems. They work by stimulating the colon, and with continued or long-term use, the colon comes to rely on these artificial aids and will often stop working on its own without having those. So some natural treatments to consider. Herbal treatments are considered to offer relief with far less risk. They work by increasing the amount of bulk or fiber in the diet. Some natural laxatives can include things like alfalfa, apples with the skin on it, psyllium, and psyllium, if you'll note, it's the main ingredient in many commercial laxatives as well. And then olive oil is another option. Now with olive oil, if that's going to be recommended, it should be done so sparingly because it may actually coat the intestinal lining and affect function on some people. Also, olive oil is considered a form of a wetting agent or a wetting agent laxative. So they need to drink lots of water with it, and we may see a noticeable increase in diarrhea, for example, with that presentation.